Welcome back. I'm Dr. Rahil, emergency physician. In the part 3 of cardiac arrhythmias, we are going to focus on bradyarrhythmias. Let's start with a case scenario. We have a 65-year-old man brought to the emergency department with history of collapse. His past medical history included ischemic heart disease and hypertension. Abnormal findings on examinations were heart rate of 38 beats per minute and the blood pressure of 86 over 40 millimeter of mercury. Please pause the video to look at the ECG carefully to answer the question on the next slide. So, what is the diagnosis here based on the ECG? Please pause the video to go through the options. The correct answer is option 1, which is complete heart block. Why this is correct answer, we will learn very soon. What is the next step in the management? Please pause the video to go through the choices carefully. The correct answer is option 2, which is injection atropine 500 microgram intravenously. Now let's learn in detail about heart blocks and various treatment options. Before we dive into various types of heart blocks, let us first learn briefly about the conduction system of the heart, which will make it easy to understand this topic. The conduction pathway is made up of 5 elements: the sinoatrial or SA node, the atrioventricular or AV node, the bundle of His, the left and right bundle branches, and the Purkinje fibers. The electrical stimulus starts at SA node, which is a natural pacemaker. This causes depolarization or contraction of the atria, and which is reflected by the P waves on the ECG. The stimulus eventually reaches AV node, and the time it takes is reflected in the PR interval. Normal PR interval is 0.12 to 0.2 seconds, which equates to 3 to 5 small squares. From here, the conduction reaches ventricles through the bundle of His, right and left bundle branches, and Purkinje fibers. Depolarization or contraction of ventricles are reflected by the QRS complexes on the ECG, and repolarization or relaxation of ventricles are reflected by the ST segment. Before we discuss heart blocks, let us first briefly talk about bradycardia, which is defined as heart rate less than 60 beats per minute. It is physiological in young fit people. Other common causes include medications like beta blockers and some calcium channel blockers. Coming back to the heart blocks, there are 3 types, and we are going to discuss each of them in the next few slides. Let us start with first degree AV block, which is defined as prolonged PR interval that is more than 0.2 seconds, which equates to more than 5 small squares on the ECG. It is not a true block but a delayed or slowed AV conduction. It does not require any further investigation or treatment. Second degree AV block is defined as an occasional non-conducted P wave resulting in a long RR interval. It may either be Mobitz type 1, also called Wenckebach, or Mobitz type 2. Mobitz type 1 or Wenckebach phenomenon is due to progressive slowing of each subsequent impulse in the AV node. There is progressive lengthening of the PR interval until a normally occurring P wave is not followed by a QRS complex. It does not require any specific intervention in stable patients, apart from treatment of underlying or precipitating conditions, if any. Mobitz type 1 block is not an indication for permanent pacemaker in asymptomatic patients. Mobitz type 2 second degree AV block is usually indicative of underlying disease of the His Purkinje system, characterized by episodic and unpredictable failure of His Purkinje pathway to conduct the impulse from the atria to the ventricles. The block occurs below the AV node and within the bundle of His or both bundle branches, and is usually an indication for a pacemaker even if patient is asymptomatic. Third degree or complete AV block occurs when there is complete failure of the AV node or his Purkinje system to conduct impulses from the atria to the ventricles. This presents with AV dissociation and an escape rhythm that is either junctional or ventricular. These shows severe bradycardia and complete AV dissociation with independent atrial and ventricular rates. What it really means is that there is no relationship between P waves and QRS complexes, but the distance between two P waves and two QRS complexes will be equal throughout the ECG. Looking at this ECG, we can easily appreciate that there is no relationship between P waves and QRS complexes. Heart rate appears very slow. There are around 10 big squares between two QRS complexes, and this makes the heart rate around 30 beats per minute. That is 300 divided by 10 equals to 30. There are many causes of complete heart block, most common being ischemic heart disease. The other significant causes include idiopathic fibrosis of conduction system, cardiomyopathies, post-cardiac surgery or valve replacement, medications, and electrolyte imbalance. This is the flow diagram on the management of bradycardia from Advanced Life Support course by Resuscitation Council UK. The first assessment in any patient with bradycardia is to find out if there are any life-threatening features like shock, defined as systolic blood pressure less than 90 mm of mercury, history of syncope or loss of consciousness, presence of ischemia or infarction on ECG, and severe heart failure or pulmonary edema. If any of life-threatening features is present, patient should be given injection atropine 500 microgram intravenously. The dose can be repeated up to 3 milligrams in total if there is no satisfactory response. If still there is no improvement in patient's condition, then patients should be started on isoprenaline infusion 5 microgram per minute or transcutaneous pacing while the preparation is being made for transvenous or temporary pacemaker. In the absence of life-threatening signs, patients should be assessed for any risk for asystole. Risk factors for asystole include history of recent asystole, Mobitz type 2 AV block, complete heart block with broad QRS complexes, or ventricular pauses for 3 seconds or more. If any of these risk factors are present, patients should be treated with atropine followed by transvenous pacing with or without isoprenaline or transcutaneous pacing as the clinical situation dictates. In the absence of risk factors for asystole, patients can be observed and monitored. Let us revisit the clinical case which was at the beginning of this presentation and briefly discuss the management. Here we have 65-year-old male with complete heart block. He has two life-threatening features which are history of syncope and presence of shock, that is blood pressure of 86/40 mm of mercury. And the question was, what is the next step in the management? And paying attention to the wording, it did not ask the definitive treatment. So the correct answer as per Advanced Life Support course is injection atropine 500 microgram intravenously. Option 1 is to be considered as a next step if there is no satisfactory response to atropine. Injection noradrenaline can be an alternative as a temporizing measure if isoprenaline is not available. Permanent pacemaker is the definitive treatment. This is the summary of heart blocks with the help of mind map. There are 3 types of AV block. First degree AV block is characterized by prolonged PR interval. Second degree AV block is subdivided into Mobitz type 1 or Wenckebach, where there is gradual prolongation of PR interval, and Mobitz type 2, which can be 2:1 or 3:1 block. Third degree heart block is characterized by complete AV dissociation with no relationship between P waves and QRS complexes. Indications for pacemaker insertions are Mobitz type 2 and complete heart blocks, as well as patients with life-threatening features or risk of asystole. That's it for now. Thank you for watching. In the next video, I will discuss acute coronary syndrome. Till then, take care and goodbye.